Thank you. This is David Miller, and I'm one of the two presenters today, and we welcome you to today's webinar presented by Healthcare Strategy Group. The subject we are discussing today is Managing at the Speed of Change, Strategic Considerations You Must Address in 2016. And as we started putting this together, while we talk about speed in the title, there are a lot of the things we're recommending that you work on that it's going to be hard to do too swiftly. There's some things that take a lot of work, but you clearly need to be getting on top of them sooner as opposed to later. So we'll talk about those in a second. Before we begin with the webinar, just a few housekeeping issues. First, if you have questions, submit those questions via the question tab on the webinar screen on your control panel, and we will answer as many as possible at the end of the webinar. We don't identify names or affiliations, and so you won't be identified if you want to submit a question. Today's event will be available on demand on our website for viewing on Monday, November 9th. A PDF of the slides will also be available for download, and they were also attached to the webinar reminder email. And lastly, when we finish, and I'll remind you of this again, but an evaluation form will appear on your screen following the presentation, and we would greatly appreciate your feedback. I'm going to start out the discussion this afternoon. I'm the handsome one on the top. Travis Ansel is with me, is my associate and the senior manager of our strategic services division. So as we are advising clients on strategic questions, it's often Travis or myself that's doing that. So we're mostly going to talk today about what we're hearing from clients, what we're learning in our interactions with them, and what our observations are about the biggest issues that you at least need to be considering as you think about your strategic priorities for next year. Before, just a little bit about our firm. We're a management consulting firm based in Louisville. Our focus is on physician integration. So as we talk about the strategies you need to look at for next year, there'll be a significant focus on that issue. Fortunately, the way the market's going, a lot of the issues people really do need to focus on are physician related. So we'll bring that expertise to the fore as we talk through the slides. And we have a number of areas of expertise, including accountable care strategy, integrating physicians, managing employed physician networks, and so a number of things. And the graphics on the bottom are all things you can provide on our website. The left is the physician integration pyramid and how we see that process going forward. The middle one, that's a circle, is for employed physician networks and how to build high-performing networks and the strategic issues you need to address to make that happen. The last one is accountable care, showing the pillars and the foundation elements that need to be in place to do a good job with that strategy. For today's presentation, we're going to talk briefly about the major environmental trends. We didn't really try to go back and reconstruct all the data that makes us think that these are big issues. It seems to us they're pretty ubiquitous in the industry, and as we talk to clients, they're pretty common issues that we're running into and being asked about. So we're going to talk about those briefly. We're going to talk about how, discuss the impact of those trends on our client priorities and the strategies, the strategic focuses that organizations are building to address those challenges. And then lastly, or not really lastly, but integrated with those priorities, we're going to talk about what we see as some of the best practices. So we're going to talk about what people need to be doing as well as some about how they need to be doing it. In terms of the big trends, there's so much going on in the industry that but it's kind of funny when we step back, and they really predominantly fell into three big buckets. Reimbursement shifts, quality imperatives, and the consolidation in the industry, which is creating challenges. In terms of reimbursement shifts, and clearly what's going on with the federal government as well as some private insurers is driving a lot of the change of behaviors that we're seeing. We're seeing smaller increases, and the Medicare increases in particular are going up at very small rates per year, which creates a number of cost challenges, creates a number of challenges around how care is delivered, and we'll talk about those issues. Changing forms that incentivize different behaviors, and that goes, we could go on and on about that for the full hour. But everything from bundled payments and CMS getting to the point they're going to require bundled payments for some orthopedic procedures in certain markets, to the continuous development of the ACO world, to insurers coming at our clients right and left and asking them for incentive contracts, to all sorts of different to physicians who are being asked basically to, or being required to do the same thing hospitals started 3 or 4 years ago with value-based purchasing. So in a couple of years, the physicians will have the same issues with core measures, the analogous patient satisfaction measures for HCAHPS, and that'll be changing behavior. So all of those issues there. And then finally, clients being asked to take risk, and then some of them really wanting to, because with reimbursement for fee-for-service going down, there may not be a path to financial success without being willing to take risk. So we have a lot of clients that are focused on that issue, a lot of clients that are focused on bringing independent physicians into their strategies for taking risk. So a number of things there. I've alluded to some of it already, but an increasing number of quality imperatives, value-based purchasing continuing to grow for hospitals and expanding into physician practices, financial penalties such as those for readmissions, and with the advent of MIPS in practices, a lot of opportunities for the federal government to keep some of the revenue that might otherwise have come to your physicians. All of those things are creating an imperative not just to manage the finances, but manage the quality. And we are increasingly, for example, running into, and this relates to the financial risk as well, but not running into an increasing focus across the continuum of care to reducing readmissions, but also making sure care that's received is appropriate and non-duplicative. So a lot of issues there. And then finally, the consolidation in the industry. And for years, we did a lot of work with physician acquisition by hospitals, which is one form of consolidation. We've done a lot of work with hospitals who were looking for health systems to join, or with health systems who were trying to figure out which hospitals they should go after. And we're also seeing major consolidation in the insurance industry with the acquisition of Humana by Aetna, Cigna's activity in this area. So a lot of consolidation, which creates risk for our clients, because if you have 2 private insurers in a market instead of 5, the risk around your negotiations with that organization, the risk around them cutting you out of their network, all of those things create a lot of uncertainty. So as we look at the environment, those are kind of the biggest issues we see. In terms of, given those trends, what are our clients asking us about? First of all, in general, not exactly asked this way, but where must hospitals focus to master their own destinies? What do they need to get on top of to be able to be somewhat in control of how things turn out in terms of their financial success, in terms of their ability to deliver the services needed by their communities, in terms of their ability to deliver quality services? What must hospitals get on top of to be able to master those destinies? What capabilities need to be built and leveraged to navigate those market realities? So it's a good thing to know where we need to focus, but what specific capabilities do we need to have, and how do we leverage those new skills? The third question is, where must financial and human capital be focused to drive the results that we're wanting? So everybody's got a million things to do, and we can't begin to do them all. And so where do we put our dollars, and where do we put our management focus, which hopefully this webinar will help you think about that management focus issue. I mean, there are way too many issues floating around for people to address everything, so it becomes an issue of prioritization. And in fact, Travis and I had a discussion with a CEO yesterday where really he's got so many potential priorities he can't quite sort out what he wants to do. So we're going to help him with thinking through that and facilitate a planning process to kind of define what makes the most sense, and then hopefully help them lay out a plan going into 2016. And in the average market, what's the relative priority, which I think is kind of how we got to these 9 issues. There, we could have 100 strategic issues that you might want to be thinking about, but you can't. And markets vary, but this is kind of our response to what the biggest priorities are on average that we see as we wander around the world and wander around in the clients that working with the clients we serve. So this slide is really a list of those things, and I'm going to run through them quickly, and we'll talk obviously about them in much greater detail. But board focus on affiliation, given the consolidation within the industry, given the risk involved of being a standalone hospital or a standalone physician practice or whatever, we still think affiliation and consolidation is a significant issue, and we put it at the top because so much of organizational success is going to be driven by market power, and so this is kind of how you get it, by getting to be part of a bigger organization. The second thing, beginning to get on top of population health. Not that we expect every organization to be able to manage population health effectively in year 1 and do as good a job as somebody like Kaiser or Geisinger might do, but you need to be building that infrastructure and that capabilities. The third one is one that I feel real strongly about, which is a focus on employers. And I'll preface our comments by saying I'm amazed every hospital we work with makes about 140% of their bottom line off private employers, but they never talk to them. They let the insurance company be the intermediary, so we think employers focus is a big issue. Building the employed physician network capabilities is a significant issue as well. Most of our clients, if they're going to be successful in accountable care or similar models, are going to do it based on the effectiveness of their physician networks, and mostly their employed physician networks. And so we think this becomes crucial. Developing physician leaders and being able to tap into their thought processes of how to better manage care, etc., is going to be crucial. And then some things that show up every year, I think, but are increasingly important now because they're beginning to be tied to financial metrics and because of increased transparency. But greater patient satisfaction, greater improvement in outcomes are 2 things we think that ought to be on your list of potential priorities for the next year. The 8th one is ambulatory access and diversifying access across a geographic area to make it easier for patients, but also to cast a bigger net and be able to get preserve your revenue as the revenue per patient softens a bit because of utilization efforts. And then finally, measured cost reduction. So we use the word measure because we don't like a slash and burn approach, but we need to be getting focused on where we can reduce cost without hurting quality and patient satisfaction. And while that's not an area that on the hospital side we consult in, we think it's very important. So jumping to the next slide, talking about affiliation, just basically why, because size and leverage matter. You know, we had a client in Ohio 5 or 6 years ago that joined a bigger system that was based 25 miles away, and there was a lot of anxiety in the board about whether or not it was the right thing to do and were we losing community control. But the first year they were in that relationship, they got a revenue bump of $8 million just because of the managed care contracts the system was able to negotiate. So, I mean, that's an example of leverage mattering a lot because that bigger health system obviously had significant more leverage. So, you know, key considerations in the insurance consolidation is one of those. It'll increase the leverage of the insurance industry, so we may need to be within a health system that's got greater leverage. Competitive provider networks could also make your organization irrelevant to buyers. They may be able to provide a geographically dispersed market without you, so you may be better off being in so you don't get cut out of networks. We see organizations gaining economies of scale and increasing their profits if they're part of a bigger system. And there's real good data out there that shows, if you're part of a $3 billion system, your operating margin is going to be about 1.5 points higher than if you're part of a half a billion dollar system. And so size matters in terms of the economies as well. We see a lot of organizations getting into affiliations and consolidations because of the resources they need to deal with the complexities of the financial market. And if you're bigger, you can afford more resources. And then also, not to lose sight of the focusing on affiliations across the care continuum. It's not just about joining other hospitals, but joining with physicians, joining potentially with hospice and home care and long-term care organizations. So you have a better, more effectively integrated care continuum. We're working on helping an organization that we're doing some strategic work with think through their organizational strategy. And they've really come to the conclusion they have 3 operating units. They have the hospital, they have the physician group, and they also have the post-acute services that relate to that care continuum. So it's interesting to see in health systems that issue grow in importance. So how to go about doing that? I mean, our experience has been that working with the board and educating them about what you need to do, you have to have a process that kind of explores alternative affiliation arrangements, alternative affiliation models, and look at the impact of each of those on the hospital strategy. So when we get into this question, and we help boards think through this issue reasonably frequently, we look at the board education is, first of all, helping them understand the implications, what they might be giving up, what they might be gaining alternatively. So helping them do a little soul searching about the issue of control versus sustainability. And it's not always an easy discussion. I think in general boards think that they have the community's best interest at heart and that a third party probably would not. And I think that's generally not untrue, that they're correct about that. That when you get into a bigger system, the board, if they're doing their systems fiduciary responsibility, they're looking at what elements of the care process need to be here, there, and everywhere. So it may create some centralization of services, but it may not. And so boards have to think through that. We like to get them to do a vigorous process of vetting alternatives. In particular, thinking about cultural compatibility and whether that's a potential merger partner is a good cultural fit as well.
And Dave, one thing I'll point out where we say under the how, that affiliation should determine what the impact is to hospital strategy. I guess for in working with clients and working with people who have reached out to us to talk about affiliation, what we've seen from a lot of organizations is people exploring affiliation in the absence of a strategy or having affiliation be their long-term strategy, as opposed to having a well-defined organizational level strategic plan that kind of identifies where we want to go as an organization, what gaps we have to getting there, which of those gaps we can fill with our own resources, which of those we need from the outside. So I would reemphasize that the need to have a strategy in place before you really get into the affiliation discussion is going to help drive that discussion a lot better, particularly as you get into, as Dave talked about, the rigorous vetting of the different alternatives, understanding how the alternatives can help you execute your strategy versus not having that framework to think about the alternatives in will make for a much more effective process, and particularly one that boards are a lot more comfortable with in my experience.
Yeah, that's a good point. If they kind of have what their vision they're trying to create at the end of this whole process is, it makes figuring out who we could work with or who we couldn't work with a little clearer, a little easier to get to a conclusion. The other thing is that a lot of this discussion we've been talking about the perspective of the smaller hospital as opposed to the system. But as we worked with systems as well, they've got some pretty clear defined needs as well. We were talking about evaluating potential partners with one, and they were talking about financial performance of the hospital and quality performance of the hospital. And the the executives from the system said, we're way less worried about financial performance. We can turn that around. What we can't really turn around is a place that's not doing good quality, because that's going to be hard to turn around. So that system had kind of defined their priorities as well, kind of an analogous comment from the system level. The second thing we suggest doing is beginning to develop that population health management infrastructure. And we see many people kind of messing around with this, but not really having a strategy as to how they're going to do it, kind of doing strategies one-off. But clearly this is an essential capability that organizations 5, 10, 15 years from now are going to need. And so now, in some markets, you need it yesterday. So clearly a priority people should be beginning to look at. Some of the key considerations of the physician culture and the market knowledge about value-based care and reimbursement systems in the future. The biggest barrier we run into with CEOs who are thinking about getting into this is the physicians don't have a clue what they're talking about. In other markets, the physician culture's kind of been advanced, because there are a lot of independent ACOs or independent organizations that mimic ACOs that are going out and signing up independent physicians and talking to them about how rich they can get if they work with this ACO and are very successful. So in some markets, we see a lot of physician education has already happened. In others, it's like farming on rocks. And so organizations kind of struggle to make that leap with the physician community. Care coordination and beginning to get into that is key, and that's not something that most of our acute care clients have historically thought about. Data analytics and getting into that issue, along with stratification of patient risk, becomes really important. As you get into taking risk contracting, beginning to understand which patients are going to cost you the most money becomes one of the first things you need to understand. Another issue consideration is, do you have the data systems to begin to really focus on outcomes? And as a group, define what outcomes need to be managed to be successful. And that relates to the comment about reducing variation and increasing consistency of care. And then finally, we see in a number of markets, a key issue is beginning to create the vision that we're going to be a clinically integrated network somewhere down the road, maybe 3 or 4 years down the road, but it's going to happen, and that has implications on the action steps as well. So how do we go about doing that? First of all, creating a common understanding of the gaps and a plan to tackle those gaps. So you know, we've had clients who come to us and said we want to be clinically integrated, but we don't really need to understand what assets we have now or what deficiencies we have. We just want to start doing it, and that's always a challenge to manage that, because it's always a mistake. So beginning to see do an assessment so you understand the gaps is key to that, and that's what the readiness assessment below is about. You know, we always say to clients, you're not going to be successful with this unless you have a steering group with a lot of physician engagement, and we probably should have underlined physician engagement about 5 times, because we've run into organizations where the executives thought they could do this in a room by themselves, and that doesn't work out too well. But they need using that group to define the priorities and setting the implementation plan and driving that implementation becomes crucial. In the third bullet, we're talking about implementation, not implantation, but beginning to drive the organization to where they can get to the point to do contracting, that we have a common quality plan, a common set of metrics that we're working toward improving, beginning to build a care management system that reaches across the continuum and into the physician's offices and to the discharge planners and into the nursing homes, and is kind of holistic, which of course that's a multi-year endeavor. Data capabilities, which you've already alluded to, but analyzing the data but predicting risk levels, and then developing incentive distribution and risk sharing formulas. So as we do begin to gain money back from the one-sided risk ACO or direct contract with an employer, you know, we've thought about how we're going to distribute that among the physicians and the hospital, and et cetera. The last one I'm going to talk about before I turn it over to Cash is Travis. I'm reading the word Cash, is the employer focus. And as I always like to say, Willie Sutton was asked why he robbed banks, and he said, because that's where the money is. And for hospitals, the employers are where the money is. But it's interesting to see, in my opinion, it's very interesting how little focus there is on employers. I did an analysis. I couldn't find a good research article on this topic, so I did some analysis of several of the financial statements of several clients, which showed basically that all of their profits plus come from privately insured patients who are working for private employers, and everybody loses money off Medicaid for sure. I would say 94% of our clients lose money off Medicare. And so to the degree anybody's making profits, on average, the industry is profitable. It's all coming from private pay patients. So, why there's not more focus on that issue is always a mystery to me. And it seems that it's a mistake, or we would advise that it's a mistake to allow the insurers to get between that relationship and stand between you and the employers. So you need to begin to be responsive to the employers. You need to be going to talk to them. They need to understand your expertise, and I promise you they need it. And the goal should be direct contracting, where you've assembled a group of providers that's adequate to meet their needs, and you, through your population health management capabilities, can begin to manage care, but that you don't really need the insurance company serving as an intermediary. So how begin to take the capabilities you have in care management to the market, and beginning to build those capabilities is what you need to do. We've started working with a gentleman who has a history of doing direct contracting from the employer side, which is quite interesting because he brings a different perspective to the table. But you've got a lot of assets too that the employers would love to have direct access to. Your PHO and ACO investments and other similar infrastructure that you've had is of great value. You need to be engaging with the employers, and I've had CEOs tell me they didn't want to do it because they were scared they'd be asked for a bigger discount. And in my experience working directly with employers, that's rarely the starting point. But if you do go out and talk to employers, I always like taking a physician with me or a clinical person so that we can kind of build the conversation around clinical issues and begin to create a value in their perception from the clinical resources we have. You need to build your direct contracting capabilities. This is not a simple thing to do. You need a third-party administrator. You need to be able to deal with referrals and approvals of care and that sort of stuff. And then finally, a focus on prevention and wellness. And patient-centered medical home models and that sort of thing become essential elements of this as well.
Yeah, there's a lot of markets we're working in where, not to say a lot, but more than there used to be markets where, especially commercial insurers and employers are looking at the patient-centered medical home model and kind of using that as a standard for either on the insurer side, using that as a standard for increased reimbursement, or on the employer side, the employers are making judgments about who's delivering great primary care in their market and changing their benefits packages to promote the usage of those organizations. And I've heard both sides of the patient-centered medical home argument about whether it truly impacts care or whether it doesn't. But if nothing else, from a marketing angle, having your primary care physicians, and at least your employed primary care physician practices designated as medical homes, preferably level 3 medical homes through NCQA, is a big a competency that you can go out there and sell, if nothing else. So with that, I'm going to take over from Dave here and talk about our next issue, which is building the capabilities of your employed physician network. Anybody who's listened to us talk before has heard us emphasize the need to really get value out of your employed physician network. So as your organization's built out your employed network over the last 10 to 20 years, It's been about driving referral growth. It's been about trying to align the economic interests of physicians with your organization. But now what we're seeing is a lot of those networks starting to mature. The growth has slowed down or stopped. Networks are working on developing their competencies in physician practice management. Some are doing better jobs than others. But the real challenge is, how do we take the group of physicians that we call our employed network and really have them help us and help them build capabilities that are going to make us successful going into the future. And here we have, because they're the ones that can help us best manage the triple aim, which is certainly a worthy goal. So in terms of key considerations about how you build the capabilities of your employed network, I mean, the first question is really just who's in your employed network, what capabilities do you have, and what relationships do we have with those employed physicians. So, everyone probably has a hospital in their market who's like this, that chose to bypass employing primary care, figuring if we have all the specialists, people will have to refer to us. And I think those networks have, as the market shifted over the last 10 years, experienced more and more trouble because they didn't have the right primary care base. They didn't have the right medical specialties that are rising to prominence as we get more and more into population health. So having some deliberateness about who's in our group and what we're asking of them is certainly important. Dave's mentioned a lot about physician collaboration and getting physicians engaged. Our second bullet point about building a vision is really about not defining for the physicians, here's what you need to do as an employee of our organization. It's working with them as collaborative partners, preferably through some sort of advisory council or physician governance council that actively engages the physicians in the management and in the vision creation of the organization. And that's something that, as we get to the third bullet, that's something that you can really build a culture around. And we have so many clients that say we've had physicians employed for 20 years and they still operate as a bunch of independent practices, or we have some people that play nice and some people that don't. Getting physicians more involved in the governance, turning over some of the decision-making power, some of the autonomy to them, and having physicians involved in the decision-making structure is one way to get around that and just kind of start building that culture. And then the last piece is, as we talk about employed network capabilities, that's obviously probably, those are the physicians that are closest to you. Those are probably the physicians that are most important to you. But certainly in every market, there are independent physicians. Sometimes there are large groups of independent physicians who are, obviously part of our strategy. This isn't to say we should focus totally on our employed physicians, but we should have an idea about how we want them collaborating with independent physicians in the community as well. So how do we do that? We'll bring it back to engagement. We have to start having these conversations with physicians, and just as Dave said, a lot of administrators are scared to approach employers and ask them what they want. The same thing's true across a lot of client settings with their employed physicians. We're afraid to bring them together. We're afraid to give them data that they can ask questions about. We're afraid to give them meaningful power in the operation or the strategy of the group, and that's something that we have to be able to work past, and we have to put the appropriate framework around so that everybody's comfortable and the physicians can get bought in. Going down to the second bullet under key actions, just as we're complete advocates for having a strategic plan at the organizational level of your hospital or healthcare system that's renewed and refreshed every year, we're very much in favor of the same thing for an employed physician network. So taking physicians through the strategy process, helping them understand the competitive market, helping them understand the healthcare environment, helping them understand what role their individual practice or specialty plays within the execution of the network's goals. That's something that can really get physicians on board and involved in helping execute their strategy, which in turn should help execute the hospital strategy. And then the last point is about physician leadership. As we talk about engaging physicians and getting councils together and getting committees together, I mean, we really have to have physicians who get engaged and who have leadership capabilities. In a lot of hospitals, that's traditionally been the CMO role. That's not enough at this point. I mean, the employed physician network needs its own. We're very much in favor of moving towards dyad models where we have both clinical and administrative leadership over an employed physician group. We want to see physicians heavily involved either through a committee structure or something else in taking control of the quality produced by the group, how the group interacts with IT, how the group interacts with the managed care market, how the group vets what doctors come into the group and which stay out of the group. So having the right structure for physician leadership and having the right physician leaders in your organization certainly is something that helps kind of achieve that shared vision.
And you went through it, well, covered it on this slide and the last slide, but the thing that's most intriguing to me, it's always interesting to step back and look at what CEOs are asking us to help them with. And one of the recent trends is around this shared vision with the group. Rather than a full strategic plan for the group, they're saying really where we need to start is we need to get these practices that we've assembled with dispersed, unaligned views of how the world's going to work. We need to get them first together where they have a shared vision of what we're trying to create with this group. So that's kind of been fascinating. It's something that I think we went 10 or 12 years without anybody asking us to do. But of late, we've had a number of people ask us just to help them deal with that as a starting point.
And the physician leadership part of this, the last part of this discussion leads nicely into our next recommendation, which is physician leadership development is one of those things that needs to become a competency in your organization. So relying on your historical physician leaders, hoping that you have someone step up and take some leadership over different clinical areas, hoping that your CMO can serve multiple physician leadership roles in the organization. That's kind of the old model, and it's not going to suit healthcare organizations going forward. Just within the organization, obviously physician leaders are important, but as Dave talked about, when we're getting out there and we're talking to the market, we're talking to employers, we're talking to insurers, we have to have physicians who are engaged and who can help us own those relationships and transform those relationships. And those are the physician leaders we care about. So what we need going forward is not to have physician leadership happen by chance or not to push physicians into leadership roles when they're not ready, but instead we need to have, every organization needs to have a formal physician leadership development program that just as you develop your, executive talent in your organization, we should be developing our physician leaders as well. So we, in the client settings we work in, we're big advocates of identifying the people who we think have potential and giving them a lot of responsibility either through an employed group advisory board or some other sort of steering group around a key strategic issue. Here on this slide, we identify population management. But the second part to that is not only, let's identify the people and let's give them a forum to lead, but let's do our due diligence and have some real process in terms of assessment tools so we can understand what people's gaps are and help them fill in those gaps as we're developing their leadership capabilities. Let's get them into a formal didactic learning program so that they can understand not only their own organization and their own specialty or their own clinical area of focus, but understand the broader industry, understand our market, our competitive market, and where what they're working on fits in. And then finally, as part of a physician leadership development program, we always want our physician, we're again big fans of pairing clinical and administrative resources. So having the right partner, the right administrative partner for physician leaders in the organization is a key part of a physician leadership program. Okay, our next area of recommendation is having a patient satisfaction focus. Patient satisfaction important always, but increasingly important because it's becoming so visible. One, because patients are more and more able to access that data, social media, sites like Hospital Compare, sites like Physician Compare. There's a lot more information out there about how satisfied patients are with your organization, and it's a lot more accessible, which means that patients are becoming more and more empowered to make their own choices about who can satisfy their healthcare needs, rather than relying on their physician to make that choice for them, or relying on putting one hospital's marketing strategy against another. The other key part of this is, not only does it matter to get the patient volume, but it also matters because dollars are increasingly being tied to satisfaction. So we have CG caps coming up. We have to have some plan in place for how we're going to, patient satisfaction can't just be one of those things that we see a number, we see it go up and down, we say, oh, we should work on that. It really does need to become something that we strategically address and have a plan in place for dealing with. We find it useful as we talk with organizations to really define what physician satisfaction means, because it's not just a lot of it does have to do with patient care interactions, and there's a lot to be said for it doesn't really matter how long you make a person, or it doesn't really matter how great a doctor is. It matters how quickly we can get a patient in, what experience they have with trying to schedule an appointment, how quickly they get back to a room. There's so many factors besides having great, engaged, high-quality doctors that influence patient satisfaction. So we have to have a comprehensive plan that addresses all of those things. So we do that through building the right structure, the right plan, the right infrastructure for creating high patient satisfaction, and then matching that with the right incentives. So while we'll be the first to say that what happens inside the hospital, inside the patient room, is not our area of expertise, we can certainly say that in physician practices, we've seen a number of clients be able to make real gains through having the right training process, getting not just the physicians, but the rest of the clinical staff and the rest of the front office staff engaged in programs specifically designed to increase patient satisfaction, and then providing even minimal incentives. So we're helping a lot of our clients integrate patient satisfaction measures into employed physician contracts, but we also are in favor of incentives for just regular office staff, because that's one of the areas that if some of their compensation is tied to patient satisfaction, or we have some sort of small bonus for them, that does meaningfully move the needle in terms of driving patient satisfaction. And so for all of those stakeholders, both the physicians and the staff, the best thing you can do to at least start is work with those groups to define what patient satisfaction means, what measures do we care about, how do we drive those measures, and then put that on a dashboard and track that week to week, month to month, and measure, and then have the right incentives in place to reward meaningful achievement of those metrics. The next one we want to talk about is building systems to measure and improve outcomes. So just as we say patient satisfaction is increasingly important, being able to measure how we're doing on outcomes and being able to meaningfully move that metric is important. This again is important, one, because the data is increasingly out there about how an organization is doing in this area, and then two, our dollars are becoming increasingly tied to it. So for many reasons, we have a lot of incentive going forward to start really thinking about outcomes. So what we recommend is having, just as we did with patient satisfaction, having the right process, the right framework, and having the right goals identified, and then integrating that into kind of the day-to-day realities of our physicians and of our practice staff. So having some plan in place that deals with pay for performance, extremely important. And then not only doing well with managing outcomes, but being able to say we do well with managing outcomes, and having that be part of our message, our brand, our PR strategy, tying those things together. That's one thing we see a lot of hospitals struggling with. A lot of hospitals not taking advantage of the great care they deliver, or not being able to specifically state why they are better, or being afraid to state they're better than their competition at something in an area like this. Again, this is increasingly important, but one of those things that can be addressed with the right plan in place. And then the final thing we want to talk about is building ambulatory access. So we're seeing hospitals and health systems, big and small, access is becoming a key issue. It's one of those things that it's becoming increasingly important, because we're running into more and more, especially commercially insured patients choosing to bypass the traditional primary care setting and use the immediate care setting. They're using the Walgreens, the CVS's, the Kroger's, the off-brand urgent cares in your market, and they're doing that because because they can get in to see a nurse practitioner or a doctor, get their prescription, get their shot, and get out of the office. And we traditionally, as health systems, haven't created that level of access. In order to stay relevant, in order to keep our particularly our primary care volume, but really across all types of practices, we have to have practices that are located in areas that are convenient and that are close to the populations we're wanting to attract, and then we have to have the right scheduling processes. We have to have something that's accessible, and something that makes it easy for patients to get in rather than hard. And that's that commentary is obviously very focused on the practice setting, but also it's about do we have the right services outside of the hospital versus inside of the hospital. And a lot of hospitals that haven't updated their facility master plan in a while, or are still operating with a very hospital-centric mindset, are asking their patients to come park in our giant parking lot, come walk through our giant facility, and come access this service, when their competitors are saying, come drive to our, come park right in front of our ambulatory facility, walk right in the door, and get what you need done. And that's something that's certainly a differentiator, and certainly can't be controlled just through a physician relationship with the patient. So building ambulatory access, how do we do it? This really needs to become part of your physician strategy. So the plan that says, here are the physician relationships and here are the physician strategies we need to execute our organizational strategy. Access should be a big part of the geographic part of that strategy. So what markets do we wish to compete in? How are we going to penetrate those markets? What populations do we want to be near? And then do we have the right facility and the right process to make it as easy as possible for patients to access our system? As we grow and as we get more and more stuff outside of the hospital, and we're owning more ambulatory facilities, we're always a big favor of recommending that hospitals use long-term leases as opposed to buying facilities. So obviously facility development is a big capital drain, but we're always in favor of finding a long-term lease partner, even if we're doing new construction, to minimize that as a hurdle to getting the right facilities, ambulatory facilities, where we need them. And then finally, as we're thinking through where we want to be and where we want to be accessible, the last thing we'll highlight is, just as Dave was saying, go talk to the employers, because that's where the money is. When we're talking about ambulatory access and how we penetrate geographic markets, we want to put our practices where the money is. So using demographic data to identify areas that are growing, that are underserved from a primary care perspective, but is an area that we would demographically want to serve, understanding where private insurance rates are high. Those are metrics you should be using to define where you place practices, as opposed to some other methodology which may not be as strategic. And then, I'm sorry.
You may take over?
Yes, yes, please.
So the last one wanted to talk about briefly is just measured cost reduction. Kind of not a cut and burn strategy, but being deliberate about it, trying to make sure as you pursue cost issues that you don't hurt your ability to produce quality care and make patients satisfied. But this is very important, I think, because it gives you flexibility in pricing, flexibility when you go to contracting. And I think everybody's talking about, or a lot of our clients are talking about getting to Medicare profitability and that being the target. For many of our clients, that is a massive undertaking, and it's a long-term undertaking. And a lot of people are kind of panicked about this because they think, oh, the money in the private insurance market is going to go away. I don't happen to believe that, but I think it is still a worthy issue you need to be addressing. And so cost management clearly needs to be part of your strategy. We see that happening in a number of ways. One is the economies of scale that we've talked about through consolidation. And we've certainly had clients consolidate and reduce their expenses 2 or 3% just because of the economies of scale. Aligning the physician incentives so that they work with what the hospital is trying to accomplish. And over time, increasingly giving them incentives to help you manage the cost within the hospital becomes important. We're helping clients with hospital efficiency improvement programs where they incent their clinically integrated network to reduce hospital costs in certain areas and help them improve quality metrics in certain areas. So creative approaches like that are certainly part of what can be done. And then the bugaboo I see in many organizations is they don't hold people accountable. And that includes the physician leaders as well. And we think accountability is a key part of beginning to drive down the cost formula as well. So in conclusion, and Travis is back, but I'll keep talking in case he starts choking again, is our focus in this presentation has obviously been very heavily physician-driven because we think those relationships and tapping into the physician knowledge is the only way our clients are going to be successful over the long haul. Many of the issues outlined are not quick fixes, despite talking about the speed of change, which I know everybody in the industry struggles with. The problems are coming at us fast, but some of the solutions take longer term to address. So getting the physician culture built, getting the physicians beginning to think through how they can help you is no quick fix, no matter how rapid you want to make that happen. So we always urge patience, and we always urge persistence, and we always urge having the long view, even though there's some changes you'll have to make quickly. Some of those changes are not at all possible. So you need to be focused on the long term. With that, I don't believe we got any questions. We must have been very clear. I would ask you to, first of all, thank you again for your participation today. We appreciate it if you'd take a few moments to complete the evaluation form that appears after you close this window. We hope you'll join us for a future webinar event, and would urge you, if you have any questions or follow-up comments, feel free to contact Travis or myself, or you can contact us at our website at healthcarestrategygroup.com. Have a great day. Thank you.